Good morning, dear learners, and once again, welcome to the MOOC on Economics of Gender and Development. And we are in week 10, and this is module 33 on Gender and Reproductive Health, the global context. So, reproductive health is defined as a state of complete physical, mental, and social well being, rather than merely the absence of disease or infirmity in all matters relating to the reproductive system and its functions and processes. And this definition has been obtained from the general definition of health put forward by the WHO, World Health Organization. So this definition implies that individuals have the capability to reproduce and the freedom to decide if, when, and how often to do so. Integral to this concept is sexual and reproductive health and rights, which encompasses the right of all people to make decisions concerning their own bodies and to access services free from discrimination, coercion, and violence. The conceptual framework of reproductive health is evolved significantly over the last several decades, moving away from 1960s policies and that focused on population control and demographic targets. Significantly, the 1994 International Conference on Population and Development in Cairo marked a paradigm shift towards women-centered policies, formally recognizing reproductive rights as human rights. So this approach adopts a life course perspective, acknowledging that reproductive health needs exist from infancy and adolescence to the reproductive years, menopause, and beyond. Now, looking at the global issues and challenges in reproductive health, the global landscape of reproductive health is currently defined by a profound tension between the formal recognition of sexual and reproductive health rights as fundamental human rights and the structural, political, and social realities that prevent their realization. While the 1994 International Conference on Population and Development established a framework for individual autonomy, contemporary challenges ranging from gendered power imbalances to systemic political rollbacks continue to undermine its progress. At the core of reproductive health challenges are gendered social relations that constrain individual agency. In many patriarchal contexts, reproductive decisions are not the domain of the individual woman, but are governed by husbands and extended kinship structures. Research among the ferret people of South Sudan provides a poignant example. Women are often regarded as outsiders to their husband's family, and their primary social value is derived from their ability to produce children to continue the male lineage. In such environments, high fertility is frequently a survival strategy. Women may feel compelled to meet the childbearing demands of their husbands to avoid abandonment or loss of status, particularly in regions where economic opportunities for women are restricted. So, this patriarchal dividend, the series of social and material advantages men accrue, often comes at the direct expense of women's reproductive well being. Now, looking at the political rollbacks and the contestation of rights, we will see here that a significant and rising challenge is the organized global opposition to SRHR, which has increasingly permeated international policy making. Analysis of UN documents from 2014 to 2019 reveals a systematic attempt by conservative state and non-state actors to dismantle agreed language regarding abortion and comprehensive sexuality education. So these actors often use the guise of national sovereignty or traditional values to replace individual rights-based language with an emphasis on the role of the family institution. So this political shift is exemplified by the periodic implementation of the Mexico City policy, which is also called the Global Gag Rule, which prevents US foreign assistance from supporting organizations that provide or even mention abortion services, thereby silencing critical health dialogues. Furthermore, even when sexual and reproductive health services are discussed online, advocacy organizations face censorship, backless, and a digital divide where those most in need lack the internet access required to benefit from modern health communication strategies. Now, looking at a reproductive health in conflict and humanitarian crisis, we see that war and chronic insecurity exacerbate reproductive health risk by dismantling systems of social control and destroying health infrastructure. In conflict zones, sexual and gender based violence is frequently deployed as a weapon of war to symbolize dominance over a community. Displacement often leaves women and girls without access to essential services, including skilled birth attendance and emergency contraception. While a minimum initial service package provides an international standard for emergency care, it is often limited to immediate life saving interventions and fails to address the long term complex reproductive needs, such as mental health support and social integration of survivors. So, the breakdown of traditional social contracts during conflict also means that men may abrogate their responsibilities towards wives and children, leaving women to bear the full burden of reproductive morbidity and childbearing in volatile environments. And when we see the burden of maternal mortality and health system failures, we notice that the disparity in maternal mortality remains a glaring global inequality. In many developing nations, the maternal mortality rate, or MMR in brief, is 10 to 50 times higher than in developed countries. This mortality is primarily driven by three delays. We'll be talking about this in detail later. Delay in seeking care, delay in reaching a facility, and delay in receiving quality medical attention. So, structural deficiencies such as a lack of blood transfusion services or the prevalence of anemia, which affects 50 to 80% of pregnant women in some lower and middle income countries, turn manageable obstetric events into fatal emergencies. Furthermore, there is a critical need to transition from traditional birth attendants, who often lack the training to manage complications like postpartum hemorrhage, to skilled midwives integrated into a robust referral system. And looking at the adolescent vulnerabilities and unmet health needs, we see that adolescents within the age group of 10 to 19 years face unique barriers to reproductive health, including social stigma and a lack of age appropriate information. Annually, an estimated 21 million pregnancies occur among 15 to 19 years old in low and middle income countries, half of which are unplanned. These pregnancies are often the result of limited access to modern contraception and the inconsistent implementation of CSE. Furthermore, menstrual health remains an overlooked dimension. In many low income contexts, a lack of facilities and teacher support in schools forces adolescent girls to miss classes, compromising their dignity and educational attainment. A national level survey often omit young adolescents within the age group of 10 to 14 years and unmarried women due to cultural sensitivities, leading to a data gap that hinders the development of evidence based policies. And while we examine the missing signs of men's reproductive health, we see a final significant challenge is the cultural framing of reproductive health as exclusively women's business. This has led to a missing science regarding men's reproductive health, where male cancers, infertility, and the impacts of advanced parental age are often marginalized in research and service delivery. Men in low and middle income countries face substantial unmet needs for HIV prevention and sexual transmitted infected treatments. Yet, issues such as hesitancy in seeking health support and limited service access continue to be barriers. Excluding men from the reproductive equation not only ignores their specific health needs, but also reinforces the unequal burden of reproductive risks solely on women. So, in summary, we see that the global reproductive health is hindered by a confluence of entrenched gender inequalities, political opposition to rights-based frameworks, and structural deficiencies in health systems. Addressing these challenges require more than clinical solutions. It demands a fundamental shift in gender power dynamics, the protection of rights-based language in international forums, and a comprehensive approach that includes adolescents, men, and those living in humanitarian crisis. Now let us focus on a comparative analysis on these issues between developed and developing context. The disparity in reproductive health outcomes between the global north and south, that is developed and developing world, represents one of the most significant manifestations of global health inequality. While reproductive health is a fundamental human right, the ability to exercise this right is profoundly mediated by a nation's economic status, health infrastructure, and prevailing gender norms. And with regard to maternal mortality and the quality of care, we see that as we have already discussed, that maternal mortality rate serves as a stark indicator of the divide between developed and developing nations. In developed nations, the maternal mortality rate is remarkably low. For instance, Norway records approximately 6 deaths per 1 lakh live births, and the United Kingdom and Singapore records roughly 10. In contrast, many developing nations face figures that are 10 to 50 times higher. For example, in Afghanistan, it recorded rates as high as 1,700, while South Sudan faces a maternal mortality ratio of 789 deaths per 1 lakh live births. However, as per latest data available from World Bank, Afghanistan saw a huge reduction in maternal mortality between 2000 and 2023 from 1,372 to 521. And South Sudan has improved from 3,845 in 2000 to 692 in 2023. Deaths per 1 lakh live births. But again, these figures are still very high in terms of global comparison. So these differences are often explained by the three delays: the delay in discharge to seek care, the delay in reaching the facility, and the delay in receiving quality medical attention. And in rural areas of India, Bangladesh, and Indonesia, many births are still attended by relative or traditional birth attendants who are often unable to manage obstetric emergencies like postpartum hemorrhage. Success stories like Sri Lanka demonstrate the impact of structural change by ensuring 95% births are attended by trained midwives and supported by an organized referral system. Sri Lanka has reduced its maternal mortality ratio from 1,500 in the late 1940s to just 90 by the mid 1990s. And as per World Bank's latest data, the maternal mortality ratio in Sri Lanka has further improved from 68 in 2000 to 18 in 2023. And with respect to reproductive efficiency and patterns of loss, we notice that a unique comparative metric is reproductive efficiency. That is, the proportion of conceptions that result in a child surviving to the age 15. So globally, roughly 58.6% of conception result in a surviving child at this age. However, the causes of reproductive wastage differ by region. In sub-Saharan Africa, reproductive loss is primarily driven by high infant and child mortality rates, which account for a significant percentage of total losses. Conversely, in more developed regions where child mortality is low, reproductive wastage is more often driven by high rates of elective abortion. So interestingly, research suggests that as reproductive efficiency improves, couples in developing nations gain the confidence to transition from natural to controlled fertility, increasing their use of modern contraception to ensure planned births. And looking at the issue of adolescent reproductive health and data gaps, we notice that adolescent pregnancy remains a critical concern, but the focus of research and policy varies significantly. In low and middle income countries, an estimated 21 million girls aged 15 to 19 become pregnant annually, with 50% of this being unplanned. The risks are particularly acute for very young adolescents in the age group of 10 to 14, who are 5 times more likely to die from pregnancy-related causes than women in their 20s. So, a major challenge in developing contexts is the data gap. National surveys such as the Demographic and Health Survey (DHS), as we call it, often omit adolescents aged 10 to 14 years age groups or unmarried women due to cultural stigma, leaving policymakers without the evidence needed to protect these vulnerable groups. And in developed contexts, the discourse has shifted towards the social and biomedical implications of advanced maternal age. The births at 35 years and plus. And advanced paternal age reflecting demographic shift toward delayed childbearing that is prevalent in the global south. Now, with regard to access to technology and preventive services, we notice that the digital divide and disparities in medical technology further separate the two contexts. Assisted reproductive technologies, ART, such as IVF, in vitro fertility, are increasingly integrated into health systems in the global north. Yet, less than 1.5% of people in Africa have access to such services. Preventive care for reproductive cancers shows a similar divide. Cervical cancer is a leading cause of death for women in low and middle income countries, largely due to a lack of cytological screening and SPV vaccination programs. In developed nations, these cancers are often caught early through routine screening and are highly manageable. Furthermore, gender based violence exerts a heavy economic toll in developing regions. For example, in sub-Saharan Africa, it is estimated that every 1 percentage points increase in women subjected to gender-based violence reduces economic activity by as much as 8%. While gender-based violence is a global issue, the lack of support services and legal protections in many developing countries exacerbates its impacts on reproductive health and economic development. So, in summary, while developed nations focus on the nuances of reproductive choices and the management of delayed childbearing, developing nations continue to struggle with basic survival and health systems failures. So, bridging this gap requires not only the transfer of medical technology but also the dismantling of patriarchal structures and limit women's agency and a commitment to robust inclusive data collection. Now, in the previous discussion, we noticed two terms basically. One was the patriarchal dividend, and the other is the three delay model. So, let us briefly discuss these two models in brief. The patriarchal dividend is a concept describing the collection of political, cultural, economic, and social advantages men accrue from a gendered social order that profoundly shapes reproductive health outcomes by contrasting individual agency and reinforcing high risk childbearing patterns. In environments where men have limited source of pride due to poverty or chronic insecurity, conformity to these hegemonic practices provides them with a sense of security and privilege, often at the direct expense of women's health. So, according to many studies, the patriarchal dividend affects reproductive health in several critical ways. First is the constraint of reproductive agency. Gendered power dynamics ensure that decisions making regarding sex and reproduction remains the domain of the man and his family. In many patriarchal societies, women are socialized to believe their primary role is to bear children for their husband's lineage, and they are often viewed as outsiders to the family unit whose status is contingent to their fertility. This lack of autonomy means women have little power to decide the number, spacing, or timing of their pregnancies. And with regard to high fertility as a surviving strategy, we see that because women lack economic opportunities and fear abandonment, they often use childbearing to secure their position within a marriage. So, fearing that a husband may look for another wife if childbearing demands are not met, women may choose to have many children to avoid loss of social status. This leads to high risk pregnancies, as women may continue to give birth even when it endangers their physical well being. So, with regard to maternal morbidity and mortality, the unequal distribution of power translates into higher rates of maternal death. So, D3 delays in seeking care, reaching facilities, and receiving quality medical attention are often exacerbated by a woman's inability to make independent health decisions or access financial resources. For example, in South Sudan, women disproportionately bear the burden of reproductive morbidity and mortality due to these entrenched inequalities. And with regard to the missing signs of man's health, as you already indicated, we see here that the patriarchal dividend reinforces a cultural script that frames reproductive health as exclusively women's business. This has led to a lack of biometrical knowledge regarding man's reproductive health, including the risk of advanced paternal age and male specific cancers. By excluding men from the reproductive equation, health systems not only ignores man's specific needs but also reinforce the unequal burden of reproductive risks solely on women. So chronic conflict can further exaggerate the patriarchal dividend, allowing men to act with impunity. The breakdown of traditional social contracts often results in men abrogating their responsibilities towards their wives and children, leaving women to manage reproductive health and childbearing in volatile environments without the support they were traditionally promised. And now, looking at the three delays model, as we are already indicating in this model, the three delays model is a framework used to understand the primary factors contributing to maternal mortality, particularly in developing countries and conflict zones. This model posits that maternal deaths are often not merely the result of clinical complications, but are instead driven by systemic and social barriers that prevent timely medical interventions. The three specific delays identified in different studies are as follows. First one is the delay in deciding to seek medical help, as we have already indicated. This first delay is often rooted in social and structural factors, such as a lack of knowledge regarding the signs of obstetric complications, the low social status of women, and gender power dynamics that prevent women from making autonomous health decisions. And in many patriarchal societies, a woman may need permission from her husband or his family before seeking care, which can prove fatal during an emergency. And the second one is the delay in reaching a facility. So it involves physical and geographical barriers. It is frequently caused by a lack of adequate transportation, poor road infrastructure, and long distances to the nearest health center equipped to handle obstetric emergencies. And in war-torn areas, this delay is often exacerbated by the total disruption of transportation services and general insecurity. And finally, delay in receiving quality medical attention. So this is the final delay that occurs even after a woman reaches a health facility. This is often due to structural deficiencies within the health system, such as lack of trained medical personnel, like skilled midwives, a shortage of essential supplies, such as blood for transfusion or oxytocics for postpartum hemorrhage, and poor referral systems between primary and tertiary care. So, addressing these three delays is considered essential for reducing maternal mortality ratios, which remain significantly higher in low and middle income countries and in conflict affected regions compared to the developed nations. So, let us come to the conclusion of this discussion. So, we have seen that the global landscapes of gender and reproductive health has shifted from a mid 20th century focus on population control toward a rights-based paradigm established at the 1994 International Conference on Population and Development. This modern framework recognizes reproductive health as a state of complete physical, mental, and social well-being, where individuals possess the autonomy to decide if and when to reproduce. However, the realization of these rights faces significant socio-political opposition, including a systemic rollback of agreed language regarding abortion and comprehensive sexuality education in United Nations documents. And a central challenge is seen to reproductive agency is the patriarchal dividend, which refers to the collective political, economic, and social advantage men accrue from a gendered social order. And in context of chronic insecurity and poverty, such as we see in South Sudan, men may conform to hegemonic practices to maintain status and security, often at the direct expense of women's health. So, in these societies, women are often viewed as outsiders to their husband's lineage, and childbearing becomes a survival strategy to avoid abandonment or loss of social status. This dynamic reinforces high childbearing patterns and limits a woman's ability to make autonomous decisions regarding contraceptions. Maternal mortality remains a glaring inequality, frequently analyzed through the 3D model. This model identifies three critical barriers. First one was the delay in deciding to seek care, often due to low female social status or need for a husband permission. The second delay was the delay in reaching facility, which was caused basically by poor road infrastructure and lack of transport. And the final delay we see is in receiving quality medical attention, which results basically from shortages of trained personnel and essential supplies like blood or oxytocics. And comparative analysis revealed that while developed nations focus on managing advanced maternal age, developing nations struggle with high adolescent pregnancy rates and basic health system failures. Metrics such as reproductive efficiency, the proportion of contraceptions resulting in a child survival to age 15, show that losses in sub-Saharan Africa are primarily mortality driven, whereas losses in more developed regions are often driven by higher abortion rates. Ultimately, investing in sexual and reproductive health and rights is not only a human rights obligation but a strategic necessity as it catalyzes progress in gender equality, economic growth, and climate resilience. So, thank you, dear learners. And with this, we come to the end of this module. And in the next module, we shall discuss these issues with special reference to India. Thank you.